This is Dr. Satish Ramkumar. He is a poor squash player. He is first and foremost, he's not very good at squash. He's a cardiologist based in Melbourne, Victoria, and he's going to share with us everything he wants to tell us about his job and how he got there. And I know Satish has a very interesting story, actually. He has a convoluted story, I believe.
Convoluted story. Okay.
Tell us, Satish, what's going on.
Where did you finish high school, Satish?
Where?
Yeah.
So I finished in 2002. It's in Haileybury College. So
Okay.
A while back.
And you didn't apply to medicine first, did you?
No, I did. I didn't get into medicine actually.
Dang! I should have done more research.
Yeah.
All good, mate.
Clearly. I was going to say your journalism's better than your squash game, but
oh my god.
There's probably a recurring theme where I've not got into training programs and got into medicine first time. So it's happened at multiple stages during my training, which I think is quite relevant to looking at a lot of the questions from the guests or the listeners. So I actually did a year of software engineering at Monash, surprisingly, and transferred to medicine after 1 year to Melbourne.
So was that the plan, you just pick software engineering as this is my backup and I'm going to sit the GAM set and try and get into medicine?
So I wanted to always do medicine, but I didn't have a backup. So I didn't actually know what I wanted to do outside of medicine, which, when you're doing all those year 12 applications, you sort of have to put something on paper and I sort of just missed out at Melbourne Uni from going straight in from year 12. So I think this was back when it was predominantly undergrad. So my plan was essentially to try and get in, which I only had about 2 or 3 places, I think, and then go for graduate entry if that wasn't the case. So it was interesting doing software engineering for a year, but wouldn't have seen that as a career for me long term. And I'm glad that went down the medicine pathway because I can't see myself sitting in front of a computer all day coding.
Yeah. Did you at least enjoy software engineering for that 1 year or not really?
Yeah, it was actually really fun. I mean, I think it was one of those things where I enjoyed doing it. But again, doing something for fun versus doing something as a career, I think are 2 different things. So
yeah.
I don't think
so then you went to Monash Uni?
So I went to Melbourne. So I did
all right.
a year at Monash and then transferred to Melbourne Med. So I did a 6-year undergrad program there.
Yeah.
And then
6 years.
6 years, did a BMed SAR year, went to St. Vincent's and Geelong for my sort of clinical schools. And then, this was back in the day where, the Melbourne students typically stuck with the Melbourne hospitals and the Monash students typically stuck with the Monash hospitals. So I was actually one of only about 3 or 4 that actually went to Monash Health or Southern Health, as it was back then, from internship. So
was there a reason why you picked that place? Just where you lived or?
Well, 2 reasons. One, I didn't get into St. Vincent's, which is my first preference. So
it's going to be a recurring theme, I think.
It is.
St. Vincent's is awesome, by the way.
Yeah, St. Vincent's
is a great hospital.
It's where I was trained as a student and wanted to stay there. Unfortunately, didn't get a spot.
Yeah.
But I must say it was a blessing in disguise because I live in the southeast of Melbourne. So I thought about
that well.
Either having to move to the city or commuting, is obviously difficult. So I actually spent 12, 13 years at Monash Health. So pretty much did all my training there.
Now, okay, so I don't really want to talk about what internship was like 100 years ago. We have rapport, Satish and I, by the way. We have rapport. I'm not just trying to be mean to him.
Awesome.
Now, I recall when I was in medical school, you were a medical registrar, and you were giving us advice. I think it must have been first year or second year. I can't remember the advice specifically, but I remember you telling me that you initially wanted to do surgery. Is that right?
Exactly.
orthopedic
Yeah.
surgery specifically. Actually, no, I
Orthopedics.
think you were discouraging us. You were
Wow.
discouraging us from doing surgery, actually.
So you've done your research clearly, or you've got a good memory.
You wanted to do orthopedics first.
Yeah,
Tell
well, I
us
think
about
it was.
that.
So I did a BMed Sci in orthopedics and had a great mentor. And when I did my internship, I started with a surgical rotation, and then did orthopedics at Traralgon, and really enjoyed it. And when the applications for second year were sort of due, I hadn't actually done any medical terms at all, so I really didn't have any sort of exposure to gen med at the time. So given that, and I wanted to do something procedural, I did a surgical resident year. So started that and started off with orthopedics actually in my resident year, and within 4 weeks I realized that I wasn't cut out to be a surgeon and didn't really enjoy being
Why
in
was
theatre.
that? Why was that? What did you not like about that? Because like in your mind, you'd sort of created this idea of what orthopedic surgery was like. What were the differences?
Yes. Well, I think what I realized is I think what you have in your head as what would be a great career as a student doesn't necessarily translate to what a great career is once you're a resident registrar onwards. So I think the first thing I realized was, as an intern, the predominant job that I had in Traralgon was actually the peri-operative medicine, so managing all the medical complications post-op. Because yes, you go to theatre and things, but a lot of the time you're managing, the sepsis and pain management, all these sort of things. And I realized that was actually the part of surgery I actually enjoyed, rather than the actual surgical component. So that will actually I only realized that because as a resident, I guess you spend more time in theatre assisting in more surgery. So I think I realized I enjoyed being on the wards more than being in. And I think practically I realized that my hand skills probably weren't that great. But I mean, this is as a month in after internship, so it's pretty early days. So I realized at that point that the path to surgery, unless you loved it, it was probably a chance for me to rethink. It was actually a tricky time because I sort of at that point only thought of surgery. I didn't really have a sort of a backup. But interestingly, I actually wanted to do cardiothoracics as a student. Again, when you have no idea about the realities or the practicalities of what life would be like, that's hence why I ended up doing cardiology. But I always wanted to do cardiac surgery. But then when I was a BMed Sci student, the project I wanted to do was a cardiac surgery project, and that was already taken by another student. And I happened to do orthopedics as a chance, and I really enjoyed it and had a good mentor. I went into one cardiac surgical case, which took about 5 hours. And at the end of it, I realized that I'm not cut out for cardiac surgery. So part of what attracted me to orthopedics was it seemed to be a lot faster, it seemed to be quicker procedures. But then very soon I realized that surgery wasn't really for me.
So yeah, no, it's just interesting to hear that, because obviously if you're more surgically minded, it's kind of other way around. I'm sure Hash will agree as well. We would probably kill for more theatre time in theatre rather than doing rounds and spending time on the ward. But yeah, I mean, like you can clearly see that you're probably more leaning towards kind of physician or medical
I think that's fundamentally what I didn't realize when I was an intern. And it's probably because I didn't get to do much medical terms before I did my applications. But fundamentally, I realized that being on the wards and managing patients, I found more interesting than being in theatre and doing procedures.
Was there an anxiety around the fact that you had already spent quite a bit of time developing a surgical CV? That now you're like,
good question.
I don't like this, because
absolutely.
I think that's an what is it, sunk cost fallacy, right? You put all your eggs in one basket and you've been pursuing something. Was there an anxiety around that, and how did you ameliorate that?
Yeah, so I mean, so there are a couple of issues with that. So this all happened within February. So this all happened within a few weeks of starting my resident year. So I had the option of transferring to a medical year, although that was actually quite difficult at the time. So one of the main issues, which I thought at the time was really important, is all my friends that I'd gone through internship with, they were obviously in the first year of physician training. I was in surgical training, and it was very hard for me. I met with the head of physician training to try and transfer, and it was going to be hard for me to swap directly into the same physician training year. So it actually meant that I actually had to be a year behind. So I think mentally that was a bit of a difficult thing to accept at the time, knowing that you can't sort of be at the same level as people that you've sort of did internship with. You can't study for exams with the same group.
Yeah, study group.
So that was one issue. It sort of felt like you've almost lost a year. And the bigger thing is at that point, I guess, I think back then, this was probably partly me and also partly, I guess, training at the time, is the whole concept of getting into training was never really a topic that was ever discussed. I don't remember these sort of podcasts didn't exist. We didn't really have anyone telling us how to get into training programs. I mean, we sort of had an idea that it would be difficult, but it was very vague. I don't think we had the level of understanding of the practicalities of getting into training programs like we have available now. So but at that point, would you
agree that though back in the day, I guess, there was less competition than now, or would you reckon?
There's definitely less numbers. I mean, this was before, I guess, we had a lot of the other medical schools open up. So, I mean, there was number of medical graduates obviously is a lot less. So I think competition was probably less as a result. I don't think the training place have necessarily increased a great deal. So
gotcha.
I think now you've just got a lot more people applying for the same number of. So I think back then all I knew was I wanted to do orthopedics. So as I did BMed Science orthopedics, so I had sort of a CV geared in that direction, and I was doing 2 orthopedic terms in that year. So it's quite a bit of orthopedics in the first sort of 2 years of training. So having made that switch to physician training, I could have pushed, I guess, if I wanted to, and switched to a medical year, or just done sort of, I guess, Gen Med and sort of. But I actually opted to complete the surgical year, and I must say, in hindsight, it was probably the best decision I made. So I did 4 months of neurosurgery.
Why
do you say that?
So I think
people are going to disagree with you. People are like, "Nah, it's crazy."
Yeah, I think so. I think at the time I probably would have disagreed with what I say now, because I think being I guess several years out now, you realize that 1 year doesn't make a lot of difference adding that extra year to your training. But I think the experience that I got in that year is something that physician training didn't offer, and probably still doesn't offer.
Right.
So, and I think it made me a better medical registrar, made me a better doctor in general. So I think I did 4 months of neurosurgery. I did a cardiothoracic term. So I did obviously nights and all these things, but my level, I think, having done a surgical year, my experience, I guess, managing, say, neurosurgical patients or cardiac surgery patients, I think is very helpful when you're a medical registrar managing these people and met calls and those sort of things. And at the moment, with physician training, I guess, you don't get a lot of surgical experience other than the surgical term that you would do as an intern. I think most people, that's pretty much the 10 weeks of surgery that they do is the only surgical experience they have for their whole career. So having a whole year, I think, under my belt, including these sort of specialized terms, I think makes you a bit more, I guess, well-rounded in some sense. And doing cardiac surgery, I think, definitely helps cardiology training. I think knowing, because one of the things we do in cardiology is once patients go to surgeries, we literally transfer care to the cardiac surgical team, and we're not usually involved on a day-to-day basis unless they have sort of cardiac complications like arrhythmias, etc. So knowing how they're managed from the cardiac surgery side, knowing those issues from a surgical perspective, I think keeps you more balanced, and I think makes you a better clinician. So I think it also allows you, when patients ask you about what the risks of surgery are, etc., I think having done a term, having been in theatre and doing those things, I think it helps you explain that to patients.
I'd agree with that. So you finished PGY2, you finished the surgical resident year. Did you straight away
Yeah.
then go BPT1? Yeah, okay.
Yeah, so I did
now,
3 years of
yeah.
basic physician training after that point. And at that point, it was pretty much the only physician training, especially I really enjoyed, was cardiology. I didn't really have a backup. Loved my infectious diseases term, but I didn't see myself doing that long term. And at that point, it was all interventional cardiology. So it was cardiology seemed to be the most surgical of all the medical specialties, and doing interventional cardiology seemed like it was a good fit. It seemed like it was very surgical, and you get the procedural aspects to it, and it's a physician training sort of specialty. So that sort of was my intention going in. So I did 3 years of physician training, did my exams.
But
and
spoiler alert, you're not you don't do intervention, do you?
I'm a non-interventionist, actually.
You're a non-interventionist. Yeah, there you go.
Yeah.
You're leading us down the garden path with that. But anyway, go on.
Exactly. I think I'm a classic case of where, like, things that you thought are important to you early on in your training, they completely, your priorities change, and what you end up valuing, I think, changes over time. So at that point, I wanted to do cardiology, and cardiology, back then was very, very competitive. Still is, probably more so.
Probably more so, yeah.
Yeah, so I think so I didn't get in after my third year physician training. So, essentially you do 3 years of basic training, sit your exams in your third year, a written exam and a clinical exam. And then once you pass those, you apply for advanced training, which is another 3 years. And it took me 3 attempts to get on to cardiology training. And I did a PhD during that time. So the first time...
We're gonna flesh this out. For those who want more information about BPT, then refer to our last episode, but we're going to gloss over that. So what was your first application like? What happened?
Yeah, so I think what you mentioned before about my CV not being geared for cardiology, I think was partly related to that. So I made the decision to switch from surgical to medicine, and hence I had no cardiology experience, had no research in cardiology at that point. So I was sort of behind the 8 ball. So I got an interview, obviously did cardiology as a resident, had good references, etc., passed my exams, all those sort of things. But got an interview but didn't get a position. I think I was relatively close, but not close enough, obviously. So I did a year as a general medicine advanced training. So and signed up to a master's of clinical epidemiology at the University of Sydney. So at that stage, I guess the college or the advanced training committee weren't as clear cut, or I guess weren't as clear as to what transparent, probably the best word, about the guidelines about what you need to get in. So, I mean, there were sort of broad categories of, clinical experience, references, research. So I sort of tried to tackle those areas. I mean, research was a big thing. And I thought the best way to go about it was to get clinical experience. So I did 6 months of cardiology during my first year of general medicine advanced training. And I did 6 months of general medicine. And I started a master's sort of part-time online during that time, just to sort of get some experience in clinical epidemiology and statistics. And the next year, I actually didn't even get shortlisted for an interview. So that was sort of took me by surprise a bit. So I went from sitting exams, first attempt, nearly got onto the program. And then the next year, having done all these things, had more experience in cardiology, had started a master's, etc., actually happened to be, I guess, a more competitive year. I wasn't even shortlisted for an interview. And generally with cardiology, there's about anywhere from 10 to 15 jobs between Victoria and Tasmania. And at any one time, you have about 120 people applying, and you have usually about 25 people getting interviews, roughly. So although I thought I'd improved my CV and my experience, I was actually going backwards, not forwards. I wasn't getting closer.
In retrospect, do you know why that was the case?
Yeah.
Was it more competitive that year, or did you go about it wrongly?
I think there was probably, I mean, it's hard because again, they weren't as transparent. I think there's probably factors that relate to me. There's probably factors that relate to the training committee. So I think on a personal level, I probably should have spent more time doing research. So the time that it took for me, so I used to, do extra cardiology clinics and try and sort of, I guess, build up my clinical side. So what I valued was the clinical experience. And I had one of my consultants tell me that said, had I taken that time and just done a research project, I'd have probably got on the program. So I think one of the things I didn't understand was the importance of research as opposed to clinical experience. So that was because I guess it's a sort of another category in the application process. I think that the second thing that I probably didn't realize was probably that doing sort of a general medical year is not really, I guess, expanding your training as opposed to doing, a dedicated cardiology year or doing a research year, which
I mean, there wouldn't have been unaccredited cardiology
I think
registrar jobs.
that's the issue back then is you couldn't have done one, so we didn't have an unaccredited cardiology position. Which I mean, there's a lot more now. So most people would have taken a year off and done a research year, or sort of essentially created their own unaccredited year. So, so it probably wasn't unique enough. I was sort of doing the default pathway for most people is they do a year of general medicine advanced training, and then sort of try and reapply to a specialty.
I mean, I can understand the rationale though, right?
Yes.
You just finished BPT, you need to finish some advanced training. You can't just be a BPT. So
exactly. I mean, I think
it makes sense. The system almost forces you into doing Gen Med AT.
Yeah, and I think the thing with general medicine training is it still gives you important clinical experience. I think general medicine is a very good sort of career choice, and I guess we're going to talk about this because I ended up doing a couple of years of general medicine. And I think thirdly, it gives you the security of having an accredited advanced training program. So your career is still advancing, because if you do an unaccredited year, or if you just do a year of research, you can't accredit that towards any form of training. Whereas if you do general medicine, I guess you've got, it's accounting towards a year of some form of formal qualification. So you have a backup at least. So I think there were probably reasons for why I did general medicine. I think the other thing also is at that time, the college had too much of a weight towards research. They probably, I guess, valued that more compared to clinical experience. And they shifted the bar too much in that year, looking back. And I think they've tried to sort of get a bit more even. So obviously at that point, that was probably my most difficult year, looking back at my training, because I said, done all these things, passed exams, etc., but I wasn't getting any closer. So I had sort of a couple of options at that point. So I had the option of just doing another general medical year and sort of going down the same path and trying again. But I must say, not even being shortlisted for an interview, I had a feeling that wouldn't get me anywhere closer. I actually had two options at that point. So I had an interview at Launceston. So Launceston is a bit, so Victoria and Hobart are part of a statewide match, but Launceston's outside of that centralized match. So there are accredited positions. So they're accredited with the college. So you still get the same sort of level of training, but they're not part of the Victoria match. So I had an interview there, and I had a fairly good chance of getting that position. So on one hand, I had an interview with potentially an offer to get into cardiology training at Launceston. And on the other, I had some colleagues or a registrar of mine recommend I do a PhD and sort of really commit to research. So I met my research supervisor in Hobart, who was working there at the time, Tom Marwick. So met him. He offered me a PhD. So I had the option of doing a PhD or the option of essentially attending this interview and getting on the program. And I asked a lot of people what I should do. And I must say, probably 90% of them said, just go for the interview, take the job, get on the program. Which, and I think it was around that time.
Now explain why you wouldn't do that.
I think it was around
research.
I think it was around that time that I probably got the best bit of advice from a consultant of mine that I think even to this day, I think is very true. And I think it's important for everyone to sort of think about this. So a consultant I chatted to, he was involved in the selection process, and he said, yeah, there's nothing wrong with getting training at Launceston. It's a great place to train. But what he said was, don't influence your decision based on registrar training. Think about your life as a consultant. And I think it's very important because we don't think about it like that, because you're only a registrar for about 5 years and you're a consultant for about 30, 40 years. So an extra year or two to get onto a program, to get the right training program is okay.
Matters.
Because you're going to be a consultant in that field for 30 years, 40 years. So I think it resonated with me for a few reasons. I think number one is I had an option of doing general medicine training. So I had an option to just continue to do 3 years of general medicine training. I would have got a consultant job, being a physician, gone down that process. But I think deep down I knew that my interest, although I enjoyed general medicine, was in cardiology. So I think it sort of reinforced that I should sort of persist with cardiology. So I think that's important. I think the number one thing for cardiology, as it is with most specialties, is perseverance. I think it's probably the number one thing you need to have. Is the vast majority are not going to get in the first time. So you're going to have to deal with some form of disappointment at some stage. The second thing is, rather than take what looked like an easier option towards training and I guess finishing your training at a faster rate, I deviated and took a longer process. Because one of the things with a PhD is you can't start a PhD and then apply the following year. So I made a commitment that if I started a PhD, I wouldn't apply the following year. So essentially,
what was your PhD on?
So I did my PhD on atrial fibrillation and looking at imaging markers of risk prediction. So sort of partly clinical, partly echo-based. So when you start, I guess,
do you love research? Like, do you thrive off it? Does it give you?
Yeah,
does it spark joy?
I certainly enjoyed my PhD. I certainly enjoy research. I wouldn't call myself an academic. I certainly am involved with research to this day, but I'm certainly would primarily call myself a clinician with an interest in research rather than the other way around. And there are people that are 50-50. There are people that are primarily academic that do a bit of clinical work, but I primarily see myself as a clinician with an interest in research.
Because that's interesting, because pretty much everyone who has talked to me about a PhD, for example, is you should only do a PhD if you absolutely love research, because it's a huge commitment. But obviously in your case, it was also, you enjoy research, you like it, it's interesting, it's valuable, but it was also a means to help you get into cardiology, into the training program you wanted to get into.
Yeah, so I did it with very limited research experience. I literally only done a poster or something prior to that point. And part of me doing the master's was to get some of those research skills, but because I ended up going down the PhD path, I actually had to do a master's and PhD together and sort of accelerate everything. So I think PhDs are not easy. I think you have to dedicate 3 years, 4 years of your life to full-time research. So it can be quite isolating because you're looking at this niche thing. But I found it very enjoyable. I found it very rewarding. I think we can fall into the trap of just doing the same sort of clinical thing year on year. So for me, it was quite refreshing to do something different. So I didn't have to sort of get up at 7 in the morning, get to a ward round at 7:30 in the morning, work till 5, do clinics, all this on call, all these kind of things. It felt different to suddenly have the flexibility of doing work when you wanted to, talking to patients, analyzing data. And I think the skills that you learn during a PhD, you can sort of put into practice even in clinical medicine. I think when the way you look at papers, the way you analyze research, I think changes a lot when you've done a PhD and you understand, I guess, the challenges of doing research yourself. So I think it makes you a better clinician. So I think there's other skills. I think I did it primarily, I guess, as a pathway to get into training. And I think a lot of people will go down that path. And I think it's still a good pathway of getting into programs because I guess for me, it helped me, I guess, increase my research profile. So I had multiple publications, presentations, etc., which definitely strengthens your CV. I think more importantly, I think gave me a mentor, which I think is very important for people to have in the field that you're interested in. And I guess it opens the doors for opportunities down the track, I guess. So we'll talk about in terms of fellowships and consultant opportunities. But having said that, I don't think a PhD is for everyone. And I think the most important thing is if you do a PhD is you want to do a PhD for the right reasons. That is not purely just to get onto a program. That you actually want to learn about research and do that. Because I think for me, I always wanted to do a PhD. It was always on my radar, but my feeling was to do it after training, which is where 99% of people do it. So they would finish their training, get their FRCP, and then do a fellowship or a PhD after. I sort of flipped it because I sort of did mine before I even got onto the program, which I think helped in some ways. But in another sense, I guess, without having that clinical experience in cardiology, it does also limit to a certain extent how much you can get out of a PhD. I know if I did the same project now, with all the clinical experience I would have now, I would have done it in a different way. I would have probably got more out of it. So,
Satish, just to clarify, so were you doing both, so PhD and while you're working as well at the same time, or did you actually take a year off just do PhD, or what was the whole situation like?
Yeah, so this I think would have been in 2017. So this was the second year of my general medical term. So I tried to, again, because I wasn't sure about cardiology and I wanted to have that backup, I actually managed to accredit all these things towards general medical training. So I did a year as a night clinical lead at Monash. So that essentially was a general medicine advanced trainee overnight. So managing, I guess, all the specialty patients. I actually job shared with another colleague. So that ended up, because it's nights, ended up being 1 week per month. Because instead of being week on, week off, because we job shared, ended up being 1 week a month. So essentially I was doing research the other time, so PhD work during the other time, and then I was sort of finishing off my master's. So so I sort of accelerated my master's and did the PhD and sort of did a night's job for that year. Actually ended up being probably my busiest year because we had a business that we started as well around the same time.
That was the BPT prep business, is that right?
Yeah,
so let me get this straight.
For a few.
You were 1 week on nights,
is that,
and then 3 weeks.
Sponsor, is it?
Today's sponsor, exactly. 3 weeks you were working on.
Yeah, the business doesn't exist anymore, so it's there's no conflicts.
They sold it for hundreds of millions. No, I'm joking.
I wish.
Yeah, you were doing 1 week of nights, and then you do 3 weeks where you're doing finishing off your master's, your PhD, and working on the business. Is that right?
Yeah.
I mean, that's an obscene workload, Satish.
Yeah.
That is just...
That is crazy.
Anyway, all right, that's wild. So then the third application, you finished your PhD or almost finished?
Yeah, so as I said, so I get one of the things when you do a PhD is I guess you have to be committed to it. So I didn't apply in my first year of my PhD. So essentially I applied 2014, 2015, my first 2 years. Didn't apply in 2016 and applied in 2017.
So second year PhD, yeah.
Second year. So by that point, I guess the research had got to an advanced level where I guess I could complete it on a part-time basis once I started training. So, so then I started cardiology training in 2018. And at that point, I'd done 2 years of the PhD. So the last part of the PhD, I did sort of part-time whilst I was sort of training. So,
yeah. Now it's the same thing. It was CV, referees, interview, and you get on. It's 3 years cardiology training, and then you can do fellowships. Is that right?
Yeah. So you've done your 3 years of basic physician training, and there's 3 years of advanced training. So now most specialties will have core rotations in that time. So most of them are 2 core years, and the third year is a non-core year, which basically means you can do a year research, you can do another specialty for a year, you can do a more clinical time if you go overseas, whatever. But for cardiology, and I think renal is the same, it's 3 core years. So essentially it's 3 clinical years of training.
And
In
no
Victoria,
exit exam.
no exit exam. No, they've talked about that for years, but at the moment there's nothing. So your I guess your barrier, your entry point is at the end of your basic physician training before you get on, and then once you get on, there's no exams at that point. So essentially, the way the Victorian and Hobart system work is you do 2 years at a hospital. So it's a centralized process. You get your CV ranked based on those factors like research, clinical experience, references. They then shortlist 100, 120 odd applications to about 20, 25 interviews for about 10 to 15 jobs. And the interviews all done at the college over sort of a 1-day period. And then they get shortlisted and you get selected. And it's a bit like the PMCV. So you rank the hospitals that you want to work in, the hospitals rank you, and then there's some sort of matching algorithm that happens, some sort of voodoo in the background that
Behind
allocates you
closed
to a
doors.
hospital.
Yeah.
Exactly. And there might be like AFL style where they have draft picks and they trade them and all these sort of things. But
it's funny.
But essentially, whatever hospital you get allocated to, you do 2 years at that hospital. So your first 2 years of core training and your final year of training. And this is just for Victoria, and for Hobart, you do 2 6-month rotations. So in 2 other
What
centers.
did you do in your non-core year?
So this is still core. So cardiology, it's all 3 core years. So I did my first 2 years at Monash. So I stayed back at Monash to did first 2 years. I spent my third year, first 6 months at Bendigo, which actually, to be honest, is probably my favorite part of my training. 6 months there and 6 months at Western to finish the 3 years.
Yeah. And you did end up finishing Gen Med advanced training as well?
So I actually did my 3 years of Gen Med training. So technically I finished all the training requirements, but unfortunately the college didn't accredit my last rotation. So I've
that's
sort
frustrating.
I've had 2.5 out of my 3 years accredited. So, and I guess if I wanted to, I guess I could do another 6 months to get that. But I guess having finished cardiology training now, I've sort of just left it in the back burner. But at least from an experience point of view, I like to think that I've got some general medicine experience, which I think partly, we spoke about doing intervention and things. I think partly doing all this process made me more non-interventional and sort of helped me sort of go through the current sort of pathway that I am, which is I do cardiac imaging and cardio-oncology as sort of my subspecialty fields.
Satish, I would love to see your CV. It must be like 50 pages long. Man, you've done everything. You've done everything.
Just 49 pages, June.
49.9 pages, yeah.
Now, you finished training and then you did fellowship, because you were in the UK last year and you did your cardiac imaging fellowship. Did you do 2 fellowships? Is that right? Yeah.
So I think cardiology it's very much, although it's a physician training, especially you can think of it almost like a surgical training program. I think we were talking about this off-air.
Whoa, relax, man, relax. It's not just, please.
I don't want to insult any.
Opthal has entered the chat.
Surgeons, but so I think although you do 3 years of advanced training, you get your letters, so you get a FRCP at the end of the day. Very few people that I know would start practicing as a consultant cardiologist at that point. So most people will go on to do a fellowship, and most fellowships are at least 12 months in duration, and most people that I know recently have done at least 2 years of fellowship, or done a PhD, or gone overseas, or done something of that nature. So, like most fields, cardiology is very subspecialized. So, although traditionally we used to have general cardiologists who did everything, so they did angiograms, did pacemakers, saw patients, reported echoes, all these sort of things. That's not the case, and I don't think that will be the case in the future, unless I guess you choose to practice regionally, in which case I guess there's a need for more generalists. So particularly in the metro areas, most people would subspecialize. I mean, So traditionally, there's been sort of three main subspecialties in cardiology. So there's been interventional cardiology, which is sort of stents and structural intervention, which is sort of things like transcatheter aortic valve replacements, ASD closures, those sort of structural heart interventions. There's electrophysiology, which is sort of pacemakers, ablations, those sort of things. And there's cardiac imaging, which is traditionally in Australia, it's traditionally echo-based, so transthoracic echo, stress echo, transesophageal echo. But now I guess we do a bit more multimodality imaging. So we've got cardiac CT, cardiac MRI. We don't do a lot of nuclear cardiology. It's mainly done by radiologists. So, but overseas, that's another pathway. So they're probably the main three streams. And then there's several adjuncts to that. So there's advanced heart failure. So people who work in the transplant and advanced heart failure centers will do sort of dedicated heart failure training. There's adult congenital heart disease, which has evolved in the last sort of 10 to 20 years because more, I guess, pediatric patients are now living into adulthood with congenital heart disease. My sort of subspecialty of interest is cardio-oncology, which is a very new field in Australia, which is mainly looking at sort of managing cardiac complications of patients having oncology treatments. So that's sort of more well-established overseas, but very new in Australia. And you'll see as I guess we go on that we're going to get more and more subspecialists. And it's not just in cardiology. I think a lot of fields are going down the same path.
Now, before I forget, was there a key moment where you were like, oh, I don't want to do interventional cardiology? Or was it just a over the years,
I think
your lifestyle
it's
preferences or?
Yeah, I mentioned about this, your priorities do change. And I think the practical aspects to your job, I think, come into your thinking. So I think early on it was all about what do I enjoy the most? What do I want to do? And I think, even to this day, I must say, doing an angiogram and putting a stent in is probably the most rewarding experience or satisfying experience I've had in cardiology. And even to this day, I'll probably say that there's something very, I guess, tangible about that. And I must say, there are lots of days where I miss being in the cath lab. And it was certainly, I had during the second year, so during cardiology training, often first year, you're sort of doing a bit of everything, learning the ropes. Usually by second year, most people have decided on a subspecialty. And then you're sort of planning to do your applications, or if you're doing a PhD or going overseas, that process takes about 12 months to 18 months to set up. So around second year is when you start, I guess, getting more experience, you start spending more time in cath lab. I really was rethinking things. So when I was doing my PhD and I was doing sort of general medicine, I started, I guess, seeing a lot of more elderly patients, lots of comorbidities. So I started, I guess, seeing a lot more of the medical aspects. And I think at that point, I was working a lot of nights. I was doing on-call when I was doing cardiology. So, the reality of interventional cardiology is, I guess, you have to do on-call as part of your requirements to manage things like STEMIs and things overnight, which throughout your career is essentially, 1 day a week for 30 years, which I guess is when I started sort of doing the PhD, it was probably the first time in my life I sort of had a bit of time off in a sense, and a bit of flexibility, which I really enjoyed. So you could work from home, you could sort of start at 10 o'clock instead of 7:30 in the morning, work late. So I think that flexibility was one thing I really liked, and the ability to work from home. I think you start valuing your family life more. I've only had a 2-year-old. Now we don't have children back then, but I think spending time with the family, I think certainly became part of it. So not having to have those on-call commitments. And I think the reality also is some subspecialties in cardiology are a lot more difficult to get jobs in than others. And I know a lot of people ask questions about jobs. So I think that sort of starts to weigh in on things about what your career prospects are like. I think ultimately it also comes down to what you enjoy. Because as I said, I think you're going to be a consultant for 30 years plus. So you've got to pick something that you enjoy. So I think having done my PhD in imaging and having spent a lot of time managing complex and medical patients, I actually enjoyed imaging and that aspect. So I realized that I enjoyed it sort of, just as much as I did being in the cath lab, but it didn't seem to have some of the disadvantages of intervention, like the on-call and those sort of things. So, and, there was times when I was toying, could I do a bit of both? Could I do a year of interventional fellowship? Could I do a year of imaging? And some people do that. So you do have some people that dabble in a bit of two different things. So you can, so for imaging, for example, so I did a year at Monash, which is, you typically do a year of echo, TOE, and CT. And I spent a year in the UK doing cardiac MRI and cardio-oncology. And I've been back for about 7 or 8 months now. I'm back in Melbourne. But most people end up sticking to one subspecialty, and most subspecialties take more than 12 months. So if it's just echo and CT, 12 months is what most people will do. Some people, if you want to do additional imaging, like cardiac MRI, for example, there are not many centres in Australia that have high volume. So you can either go to a high volume centre here, where there are a few, or go overseas. I chose to go overseas. So I spent a year doing that. For intervention, most people end up doing a couple of years. So I know colleagues who've done 3-4 years of fellowship, both here and overseas. And then within intervention, as I mentioned, there's different forms. So there's PCI, which is sort of stents and those sort of things. Or if you end up doing structural intervention, doing things like transcatheter aortic valve replacements and mitral interventions. I mean, they take another sort of 12 to 18 months of training. So, and electrophysiology is the same. Most people would do at least 12 months just for pacing, and then to do more complex electrophysiological procedures might need another couple of years. So you might have 3 years, 4 years of fellowship, as opposed to, say, 2 years.
So it really isn't just 3 years of advanced training. It can blow out to 6 years.
Yeah, which is why I sort of related it to surgery. I mean, it's pretty much most people who do cardiology, I think, are doing 5 years usually of some sort of training. So 3 years plus 2 years of fellowship, research, whatever it is. So it all ends, I think, 5 years.
Yep. Let us blast through some listener questions that we may not have covered, because I think we've pretty much covered most of your usual things. Let's see, typical CV and timeline. I think we covered that. Like, you needed more research, you got more research.
I think now I think compared to when I went through to now, I think even it's more of a case where you need to sort of declare your interests early. So I think most people are now doing research and things as medical students. But I think, although you don't have to do it as a student, I think certainly by the end of internship, by the first year of physician training as a resident, you really want to start sort of doing research and meeting sort of consultants in that field and sort of demonstrating your interest, so that, you know, you can get those opportunities.
And Sati, how do you, I guess, do that as I'm sure listeners would love to know how you'd approach that as well. So if you're a resident or an intern and you're quite interested in cardiology and you'd like to introduce yourself to the relevant people, how would you do that, or how did you do it?
So for me, I sort of did it during my cardiology term. So I was lucky I sort of did cardiology early on as a first year physician trainee. So I think the registrars are probably the best people to contact initially. I mean, certainly the ones at Monash, they can just contact me, or and I'm sure there's likewise in most hospitals. You know, you can contact.
You're a scary guy, though. You're not that approachable.
just on the squash court, clearly.
Just on the squash court, this man is ruthless.
But, competitive, eh?
Yeah. But I think generally the simplest thing is most registrars are doing research projects already, likewise fellows. So you don't need to know the right people. I think if you ask one person, and that could be anyone in the department, they often will forward you on to the right person. So, and most departments, I know in cardiology, they're doing research in every hospital. So there's always opportunities, and we're always looking for medical students and residents to help, you know, with data collection, helping with analysis, preparing manuscripts, those sort of things. So there's a dime a dozen research opportunities.
Yeah. So there's a lot of listener questions actually. How subspecialized is practice? We talked about that. It's increasingly subspecialized. And Satish, you just interject if you want to add something.
Yeah.
Will an interventional cardiologist only see interventional cases? My guess is they would see a lot of interventional cases, but not only interventional cases. Does that sound right?
In terms of consulting, you see everything.
You see everything,
So
yeah.
probably there's probably a difference between public and private. So private, you probably will end up seeing a lot of general cardiology. So you can, I see patients who've had infarcts and stents, etc. So I see a bit of everything. Likewise, an interventional cardiologist may see a lot of valvular heart disease and heart failure. You do have, I guess, some choice in private practice about the sort of patients you want to see. So, but most people do a bit of everything. In the public hospitals, again, depending on which hospitals you practice in, a lot of people will still do general cardiology clinics, so they'll still see a bit of everything. When you're doing ward service, you'll often see a bit of everything because you're often on for general ward service. I know where I work at the heart hospital, we now have subspecialty streams. So we have heart failure, intervention, and electrophysiology sort of bed cards. So it's a bit, but most other centers, they're just cardiology units. So you see a bit of everything. So I think it's important, although we're subspecializing, that you'll probably still end up seeing a wide breadth of sort of general cardiology patients.
Yeah. I was kind of scanning through the other questions while you were talking, and I think we covered most of them. There's only two or so that are actually we might not have covered. Kind of a good segue. Like, there's two questions about job market as a consultant, public versus private job market. What are your thoughts on that? What's the job market like?
Yeah, look, I won't lie. So the public cardiology jobs are competitive. So I was lucky enough to sort of get a consultant position in both public and private. So I do sort of predominantly public and do a bit of private practice. So I was fortunate enough to get a position as soon as I came back from the UK. So I think, again, depending on the different subspecialties, the competitiveness may change. So I think one of the advantages I found in imaging, one of the reasons I picked up imaging is imaging, I think, is a growing area, particularly in Metro Melbourne. And I think the pathway to getting a public consultant position, for me at least, seemed to be a bit easier than doing, say, something like interventional cardiology, where there tends to be a lot more competition. That may change. I mean, it does change every few years because it also depends on the number of trainees that finish, and every year, you might have 1 year where everyone is doing intervention, and the next year everyone's doing imaging. So that will sort of vary. The one thing I will mention, though, is we're very lucky in Australia to have private practice, which I think is very important. I mean, I spent a year in the UK where they have very little private practice, and then it makes it very difficult for trainees when you finish training to get consultant positions because you're all applying for the same public consultant position. Whereas now in Australia, we've got the flexibility of private practice, which is definitely growing. And, you don't see any cardiologists on Centrelink benefits, that's for sure. So I think although things are very competitive, I think in private practice, there's a lot of opportunities irrespective of what subspecialty you do. And for most people, it may not happen instantly. You're not going to walk in with your ideal job day one, but it's going to evolve. And even with public, for that matter. I mean, although you don't get it first time around, things change in a department. We've got a brand new cardiac hospital, which we didn't have a year ago. So that created a lot of new opportunities. And I was lucky enough to get a consultant position at the hospital. So there will be new positions.
Serendipitous timing.
Exactly. People will be retiring. Departments will get bigger. People will be moving on from the department. So there will be opportunities. So often it is a case of being at the right place at the right time.
And the other question that is on here that I don't know if you'll be able to answer. Someone has written a current cardiology trainee based in the UK with an Australian PR. Any ideas on feasibility of coming over to practice once qualified as a consultant, be it public or private?
It's tricky. So I do have experience the other way, going from Australian training to the UK, and it's definitely possible because I guess our training is quite similar to get your training accredited through the GMC, which is a General Medical Council. So although I went just with general registration because I was only sort of there as a fellow / registrar, you can actually get your entire FRCP accredited if you do a lot of paperwork and demonstrate your skill sets. Likewise, because the UK training is quite similar to Australia, I expect that the pathway is achievable, but you need to have, I think, very clear documentation of your logbooks, so what sort of procedures you've done, your reporting experience. You need to have letters from your head of departments to outline your training. And what may happen, what I've seen previously, is if you don't get all your training accredited, there may be a period of 6 to 12 months where you may need to be supervised, or you may need to have some sort of local training before you then have, I guess, your FRCP granted, and then you have sort of full sort of access. And whether it's public or private, I think it probably just comes down to, I guess, the individual and their CV and their experiences, I guess.
Amazing. Someone said, is it worth it? I'm going to guess you're going to say, yes, it is worth it, Satish. Is it worth it?
Oh, absolutely. I mean, it's taken me a lot of years to get to this position from when I first started, but
better bloody be worth it.
I don't think I would change anything if I had my time over. I love the specialty. I think it's great. So for anyone out there who's interested in cardiology, I think it's a great career. I think it's one of the few careers that has a genuine mix of lots of things. I mean, we often get criticized for being too single organ and not sort of, general compared to other specialties. But I think very few careers in physician training give you the option of being able to do procedures, report scans, see patients in the inpatient setting and the outpatient setting. I mean, we manage patients acutely in hospital who with life-threatening complications, all the way up to those with chronic conditions. And I think, as I said sort of before, I think I don't know if anyone's asked this question, but one of the common criticisms of cardiology is about on-call and being difficult training, like other, surgical careers, etc. And again, I sort of come back to that quote that my consultant gave me, which I think I found very useful, is you're only going to be a registrar for 3 years. The on-call is, I'm not going to lie, it was pretty tough. I think that's
how many
changing.
phone calls was your busiest day? Like well over 100, I imagine.
Yeah, I think like on a weekend you could have about 250 phone calls between sort of a Friday to Sunday, and you might get about 60 or 70 during the night.
Yeah,
I think that's changing because I think with the EBA and all those sort of training requirements, I think more and more hospitals are going towards night registrars, so you're not having as much on-call commitment. So that certainly will change by the time a lot of the listeners get through the training. But I think it's important to remember that, like, although it's a difficult part of your career, it's part of your training, and it's a short period because after you have your letters, and once you're a consultant, you're going to be a consultant for the majority of your career. And once you're a consultant, I think the best thing about cardiology, which I think people don't realize, is just how flexible it is. So there are cardiologists that work 1 day a week. There are cardiologists that work 7 days a week. So yes, with public commitments, you will have certain commitments in terms of expectations for on-call and ward service and things, depending on what you do. But there are a lot of cardiologists in private practice that you have full flexibility in what you want to do. And one of the attractions I love with cardiac imaging is I can report from home. So I can do echo reporting, CT reporting from home. Yeah, and very few careers in physician training give you that luxury of being able to report from home. And that is not just at home. That could be in Queensland on a beach.
On your yacht.
On your holiday.
On
your
yacht.
On your yacht, yeah.
So definitely, I think it's worth it. I think it's a great career.
Well, that rounds out about an hour.
Amazing.
Thank you, Satish. Thank you for shedding light on cardiology training, but also being a shining example of being rejected multiple times at
I've
multiple
I've got
points in your path, but having the resilience and the clear-mindedness to continue pursuing your goal.
There's one thing I've had in my life is a lot of rejection, I can tell you. So
I think one
Go,
word that
June.
probably we can describe Satish is like tenacity. Really,
Yes, he has
what
tenacity.
a journey. Hey,
He has tenacity.
that's a crazy journey.
But also, also growing and being like, actually, no, that's not what I want. In my mind, I thought orthopedics was this glamorous thing, and then he did it. No, I think it's Thank you for sharing that with us.
Yeah, no, thanks so much for coming in.
I think it's one thing that I should have probably do mention is that although we talk about, people planning on their careers early on, I think a lot of people feel the pressure that they have to pick the right thing. I know I did, I remember. Particularly now we talk about research and how you have to start early and do all these things. But I think it's okay to take your time to get into a training program. And I think it's okay to change your mind. So if you find you do something, you thought you love it, like for me, I did orthopedics and realized I didn't enjoy it. I think it's okay to change your mind, change your specialty, even if it's a complete 360. And I think that's one of the
360 put you in the same spot, Satish.
180. So I think that's one of the things in medicine is I think the flexibility that we have is you can really pick what you want. So I think taking that extra time to really pick what you want, because it comes back to this, isn't it? You're going to be a consultant for 30 years. So you've got to imagine at the age of 55, you're going to wake up at 7:30 in the morning, drive to work, and you've got to imagine what your life is. Are you going to enjoy going to that clinic or going to that ward? And you've got to pick a specialty that the answer to that question has to be yes. I think that's the ultimate question.
Amazing. Thank you, everyone.
Thank you. Thanks, everyone, for coming in.
All right.
It's been an amazing episode. Yeah.
No problem. And if anyone has any questions or wants to get in touch, I'm happy to leave my email.
Perfect.
Yep, you're happy to take that, Hustling Ninja. I think I've said your name twice this whole time, but anyway.
So I'll beep it out, mate. All good.
He beeps it out every time, Satish. All right. Thanks, everyone.
Yep. Thanks, guys.
Thanks, Satish.
See ya.
Bye-bye.
See you guys. Bye.
See you, everyone. Bye.